We're just going to get started. So now we go from that global vision of connecting values to actions that Nancy was so good at getting us all fired up about doing and figuring out what we can contribute to that, to the more, we talked about scoping down to a more mid-range kind of vision about connecting, figuring out what our values are and making sure that we can keep working on those. Dr. Elizabeth Ryder is the Director of Academic Programs for the Institute for Professionalism and Ethical Practice, which is quite a mouthful, at Boston Children's and Harvard Medical School. What her specialty is communicating, and is also a Master of Social Work in addition to being a medical doctor. Her main interest is that communication between the doctor and the patient and doctors and other providers amongst themselves. And as I said in the introduction, she doesn't just assume that it's a touchy-feely thing that you can talk about, but you can't really teach and you can't quantify. Instead, that they've gone about quantifying it in a very methodical way, in a very eye-opening way. Dr. Ryder's research has talked about the average doctor will have somewhere between 160,000 and 300,000 interviews with a patient by the end of their career. So think of the number of opportunities you have to do that well or to do that poorly. And research that they have done also shows that when that communication is done well, there's a quantifiable result in the outcome, the health outcome of that patient. When that communication is done badly, there's a quantifiable bad outcome in terms of missed medication, medication errors, malpractice, and lawsuits. And so there's the importance on 300,000 times over a career of getting that done right. And so Dr. Ryder is going to share with us their research on how they try to get that done, how they try to improve that. So please welcome Dr. Elizabeth Ryder.
Thank you so much for that lovely introduction. That is terrific. So I have slides. It's a little more academic than the last talk, which was so inspiring. But what we're going to talk about today, the challenges to relationships in healthcare. Why should we communicate well? It's evidence-based. Relationships are the meaning of healthcare. I think we're losing that in today's healthcare environment. I'm going to teach you 3 strategies or concepts for relational competency. Patient-centered versus relationship-centered care. Think about those words. Everyday ethics, the moral aspects of practice, reflection. Talk about values and our global initiatives that are just starting up. So, the practice of medicine is an art, not a trade, a calling, not a business, a calling in which your heart will be exercised equally with your head. That's really important to remember. That's William Osler. He wrote that in 1932. But I just want to take one step back and say I'm absolutely delighted to be here. It's a special honor for me because I grew up in Colorado. And I'm getting my Colorado Western fix. I grew up in Denver in the suburbs. Went to TJ High School, for any of you who know. And very exciting. My father, Mitchell Burns Ryder, was an ophthalmologist in Colorado. I'm dedicating my talk to him today. He died in '93. Some of you might have come across him. He used to teach also at the medical school. So, questions. How many of you are clinicians? Just raise your hand. Educators, healthcare leaders, researchers. Excellent. How many of you are patients or have been a patient? This includes your flu shot. Should be most of you. And then how many of you are human beings? Okay, we are good. We're good. So, we are having a lot of threats to communication in healthcare these days. The economic environment, there's a focus on efficiency and productivity. Some feel that healthcare is a market commodity and not a right. So we need to think about these things. We have rushed 10-minute appointments. There are so many care transitions. The continuity of care is lost. There's an erosion of values. This is what's really important to me. There's less attention to values. There's safety issues, more medical errors. And then there's a primary care shortage. I mean, who's going to take care of our kids? Who's going to take care of us in the future? Important things to think about. So this says, I'm sorry, Mr. McConnell. Your insurance plan only provides for empathic nodding and a saddened downward glance. There is a $200 copay for any additional words of compassion, not to exceed 40 words or 3 expressions of sympathy or condolence. So this is a little bit about where we're at, I think, Dr. Siegel, for that slide. So I think in today's healthcare environment, efficiency, productivity models seem to have priority over relationships and caring. And I'll tell you in a minute why that's a problem. So there's a rush in clinical practice. It erodes our relationships. There's minimal time for us to talk with our patients, to get to know them as a person. Our capacity for compassion is clearly challenged. Burnout, lots of burnout, compassion fatigue, patient and clinician dissatisfaction. So think of this, in the 1980s, residents spent 20% of their time with patients. In 2012, they spent 12% of their time face-to-face with patients. Half of their time is spent in front of computer screens. The bottom line, they spend more time on documentation than they do on you. So that's pretty strong stuff. Here's a little picture about what it's like. Tell me, how many minutes, I can't read it, how many minutes do we have left? 9. 9 what? Oh, I'm sorry, 10. 10 what? 9. Oh. Now, I'm a pediatrician, a general pediatrician, and I have to tell you that 10-minute appointments, by the time the child is weighed and measured and the temperature checked, perhaps the diaper change, can't weigh him with a diaper on, you have 5 minutes left. And they're constantly saying, next, next, next. It's like a factory line. We can't treat patients like that, I think. So why is communication important? Well, we know we're starting with the single greatest problem in communication is the illusion that it has taken place. The interesting thing about that is even in excellent healthcare environments, we still have that. We still have problems with communication. So, Michael mentioned some of this. Communication is a core clinical skill. The medical interview is the most commonly performed procedure in clinical medicine. The physician performs at least 200,000 interviews in a 40-year career. So we need to pay attention to that. There is so much data. How many of you know there are a lot of studies in communication skills and relationships and how that affects outcomes? How many of you are aware of studies in that? Okay, I see about 6 or 7 hands. So that's not very many. There are hundreds of studies. And I put the citations on the bottom of the slide for you there of just some of them. That's to make the point that there are hundreds of studies that talk about how if you're skillfully a communicator, you have a relationship with your patients, you're patient-centered, you have improved patient outcomes. There's lots of them. Symptom improvement, resolution, you have better blood pressure control, shorter length of stay, better diabetes care, lower A1Cs in diabetes. You have a better quality of life in your patients, fewer readmissions, greater patient satisfaction, and improved patient experience of care. Studies show this. This is evidence-based. And you have improved outcomes for health professionals. This is really important. People are burning out and going into different careers, and we're having a shortage. So improved clinical performance and efficiency. One study actually showed a 50% reduction in diagnostic testing and referrals. Now, why is that? Well, I tell my medical students and all my other students, I do interprofessional work, that 80% of the diagnosis is in your history. So if you get that history, you will get that diagnosis. If you don't even talk to the patient, allow them to talk, get their information from their perspective, you'll miss all that. If you just read the chart, what somebody's written in it before you go in the room, you'll miss all that. So you will be a better diagnostician, you will do better treatment based on that if you communicate well with your patients and really get to know their stories. So the other improved outcomes increase patient trust, decrease burnout and compassion fatigue for health professionals, better physician satisfaction, and fewer malpractice claims and suits and medical errors. So you can just see some of the articles there. listed there. So the Institute of Medicine, their first principle for quality of care is that the development of long-term healing relationships with patients within a system of patient-centered care. So it's really all about relationships. Relationships are important. And the ability to form deeper relationships with patients goes beyond developing a set of communication behaviors or skills. We have lots of checklists, and some of those are being, have to be politically correct. People get to know how you take your licensing exams and what you can say, and you can check off if, does the person say, oh, that must be hard? Well, check, empathic. Well, maybe that's not empathy. So how do we know if someone is present, if someone has a way of being that is really going to be a good physician or other healthcare professional of any sort? I'm also trained as a therapist in social work and child and family therapist for 8 years, and then medical school, vastly different training. But we can train everybody to communicate well, to have relational competency. So how do we enhance it? How do we help people to be present? How do we enhance the ability to develop a sustainable relationship that allows for repair when mistakes are made? So we're really looking at a way of being. I've been involved in communication skills, professionalism for many years. How do we assess it? How do we teach it? It's really hard. We can assess the behavioral tasks. Do they turn off their beeper? Do they sit down? Do they have eye contact? Do they have good verbal communication, leaning forward, looking interested? But what's really going on inside? What's happening inside? And it's a way of being. It's much more than just meeting the lists on a checklist. It's interpersonal skills. It's relationship-centered. And I think authenticity and being real may be more important than mastering a checklist of skills. So how do we enhance interpersonal skills, moral growth, everyday ethics, a way of being? So relational competency, these are interpersonal skills. It includes awareness of the importance of the relationship, honesty, authenticity, presence, capacity for compassion, a caring intent to relieve suffering, and relational versatility. How many of you have heard of differential use of self? Probably only the therapists in the room. So it's you use yourself differently with different patients. You don't have a clinical guideline that's exact. Ask them this, ask them this, ask them this, ask them this. You don't have that. You actually have different ways of relating. Think of how you talk to your kids. Think of how you talk to different friends. You're still yourself. You're still importing that information. But you're a little bit different with each person. So now I'm going to ask you a question. We're going to do a fun little exercise. So pretend here's a bear in the tree. Now pretend this is your patient. This bear is your patient. So why is the bear in the tree? We want to know what's the bear's perspective. So I just want to have you call out, just raise your hand and I'll say, why is this bear in the tree? Why do you think, you have to like stretch your imagination. Why do you think this bear is in the tree? Say it again. Sleeping? Curiosity. It's curious bear. Other? Getting food? Mm-hmm. It's scared. Yes, it's scared. Other ideas? Why is this bear in the tree? It's fun. It's fun to be in the tree. Anything else? Do you think there's dogs down there maybe? Got chased up there. Maybe it's looking for honey. One more idea. Why is it up there? To get a better view. Yes, yes. Okay, let's talk about why this bear's in the tree. Do you see that tiny little thing there on the ground? That's why the bear's in the tree. That tiny thing on the ground is Jack the cat. This is a true story. My sister sent me this article some years ago. Fabulous. This Jack the cat apparently treed this bear 3 times. And then Jack's parents decided that maybe they ought to keep him inside because maybe the bear would get smart and eat him or something. So the point of this analogy, this metaphor, is to think about what is the patient's perspective? We have so many assumptions. So what is the patient's perspective? We have our own assumptions of what we think, But what does the patient think? We need to get their story. This really relates to cultural competency as well. You can have 5, let's say, for example, men in Guatemala from the same town. Well, there's going to be different cultural things that really affect those people, but each of those patients will have a very different experience in life, experience of illness. I tell my medical students when I'm teaching them that it's really a meeting of experts. So you have the clinician of any sort, not just physicians. You have the patient. The clinician is an expert in their knowledge base and what their diagnosis, what they're working with. The patient is an expert in their experience of illness, experience of care, experience of health. So it's sort of a meeting of experts. So you need to have both. It goes both ways. So those are some of the quick teaching points. Remember Jack the cat. So the bottom line, don't assume, ask, find out, and don't be afraid to ask. Many people are afraid to ask. So I'm going to teach you next 3 concepts for relational competency, just very briefly. Patient-centered versus relationship-centered care, everyday ethics, reflection, and self-awareness. So how many of you have heard of patient-centered care? Just raise your hand. Great. How many of you have heard of relationship-centered care? Not many. I would say 5 or 6 people. This is what I see in most audiences. So patient-centered care looks at the patient's experience of illness. We did that with, we didn't get it from the bear, but we were thinking about that paradigm. Views the patient and family as unique, wants to focus on their values, perspectives, needs, and culture, and tailors as much as you can their approach to the patient's, what they know about the patient. Now, relationship-centered care is different. The phrase relationship-centered care captures the importance of the interaction among people as the foundation of any therapeutic or healing activity. So, relationship-centered care, the focus is on how patients and clinicians relate to each other. It's the medium of care. It's therapeutic. Both patients and clinicians are active participants. And partnership, recognizing the patient's participation in decision-making. And great participation, what we just talked about. Relationship-centered care takes patient-centered care a step forward. It enhances it. And it's a 2-way relationship. Here's what's important that I think we're not teaching. Being present for yourself and others goes beyond just being patient-centered. You need to be aware of your own values, your own feelings, your own hot buttons. The interactions within the clinician are equally important, and I'll give you an example. As a general pediatrician, some patients, and I think those of you who are clinicians, you'll know that some patients make you go, whoa, or make you anxious, or make you cringe, or push your buttons in some way. So it's important to be aware of them. You don't have to know exactly what they are. You don't have to go to therapy. It might help for those. But I think, so what gets me is Munchausen by proxy, where a parent is harming their children, bringing them in, making them look sick. And I had a mom with 2 little girls with that. Very difficult. That was hard for me. And of course, our nurses would say, guess who's on your schedule at 10 in the morning? So I had to say to myself, what is it about this that really bothers me? Now, I don't have to work it out in a great length, but I have to be aware that this pushes my buttons. And then I can go into that patient, that mom and her kids, with some empathy and also with a curiosity, trying to learn about why is that? Why is that that it bothers me? So that's really important. So self-awareness, relationship-centered care, it goes both ways, and we have to pay attention as the clinician to our own behavior. And this goes for all stakeholders in healthcare, whether they're actually clinicians or not. So this brings up my Angelou. I may not remember what you said to me. I may not remember what you did to me, but I will always remember how you made me feel. So that's an important quote to remember. So this brings us to how do we teach this? Or how do we enhance this in our practitioners? And how do we teach in our learners and ourselves? How do we evoke attentiveness, curiosity, self-awareness, and presence? My father used to say always, be more interested than afraid, be curious. And I've used that. I have a group of very senior faculty fellows that we're training to be humanistic, 10 of them. in the Harvard system. And it's very interesting because you teach them many pearls, and that's what they've picked up. Okay, I'm going to be curious. I'm not going to go in and say, oh my God, I have to deal with that family, or this terrible situation with the patient. It's like, let's be curious. Why is that? What is the challenge? What is there? Let's be more interested than afraid. So that's another clinical pearl. The next thing I want to move on, the second concept, is the ethics of everyday practice. Clinicians and patients live in the same moral universe of universal standards, being fair, respecting each other, discussing the right thing to do in any given situation. This also applies to interprofessional care. It's how we interact, how we relate, what relationships we have with our interprofessional colleagues. And then reflection. This is the third quick concept I want to give you. Reflection and self-awareness enhance practice. There's not a lot of time to reflect these days. And Parker Palmer, that's a great book, The Courage to Teach. He says the most practical thing we can achieve in any kind of work is insight into what is happening inside us as we do it. So what is reflection? We're considering the big experience. What is the larger meaning of our experience? What's the larger meaning of our interactions? You've had a hard day at work, you've had a difficult patient situation, difficult colleague situation. Then reflect on that. What does it mean? What's the larger meaning of that? What are the expectations? What's going on? To have time to even think about it is really important. So reflection and self-awareness enhance the moral aspects of practice. So the ability to develop insight to your interactions with patients, colleagues, and unto yourself. This is also goes back to the hot button thing, to listen to patients' distress, to be willing to be present with their suffering. We don't have to fix it, and as doctors we're taught the fix-it model. As a therapist, I was taught, how do you enable your patients? How do you hear them and get their perspective? And then enable them to sort of come to solutions. So very different models. We can combine those. How do you recognize your own errors? How do you make decisions? How do you clarify your own values so you can act with compassion, technical competence, presence, and insight? And Ron Epstein, that last one is his. So and reflection promotes personal growth, cognitive growth, moral growth. Very important. So reflection and self-awareness helps physicians and other healthcare practitioners to think about their actions, to consider the underlying ethical meaning of their work, to choose to act altruistically by supporting the patient and family's perspectives. That doesn't mean you have to do it or do what they're requesting if it's not something even reasonable from many people's perspective, but to listen to it, to hear it, to sit with their suffering and be present. So Edmund Pellegrino, who I wish I knew, he died in '93 at age 96. And, 2013 he died. And actually, he was one of the founders of bioethics. He says medicine, and this applies to all to healthcare, is a moral enterprise. If you take away the ethical and moral dimensions, you end up with a technique. That's the reason it's a profession. It's dedicated to something other than its own self-interest. This is really important, and I want to make the point that this applies to all stakeholders in healthcare: clinicians, patients, leaders, administrators, third-party payers, corporate systems. Very important. So I'm going to give you a little example here. Moving beyond the script. This was in the New England Journal of Medicine some years ago. In medical, and it was a narrative. So this student said, in medical school, we're taught to follow a script, but then the script ends. Just like that, I was in over my head. I had no script, only clinical judgment, that perplexing skill that can't be reviewed in morning rounds or diagrammed on PowerPoint slides. So, have any of you felt in this position? Yeah. So this is, we can't really rely on a script. And people had, if I was doing a day-long workshop, we would talk about what this picture meant to different people, different perspectives. But we can't rely on a script, but we do have our values, and we have our authentic selves. I'm going to talk a little bit more about that. We have our motivation to help and heal, and we have our moral capacities. And so when you're in the deep weeds, with a family, with a decision, sometimes you have no idea what decision to make, you can go back to your values and think about, well, is this compassionate? Is this respectful? Does this preserve the patient's dignity? Is this excellence in healthcare? Does this have integrity to it? Does this have social justice to it? So you can go back to your values, which may help you reframe terribly difficult decisions. Because as healthcare clinicians, we come up with a lot of difficult decisions, sometimes every day. So values are the foundation of our work. And I want to ask, how many of you in your professional training were explicitly taught values? Meaning, you discussed them, you wrote about them, you told stories about them. They were explicitly addressed in your professional training. This is whether you were clinical trained, whether you were in business school, whatever. How many of you had explicit curricula on values? So we've got, so maybe about 20, or maybe even 10, I think. Not many. And I have to say that in medicine, we have professionalism. You're supposed to be compassionate. You're supposed to be honest. You're supposed to have integrity and excellence. We just assume that our trainees know that they have that they get that, but we don't teach it. Wow, that's got to connect those dots. So we have got to start teaching values explicitly, articulating them, expecting them to be shown, to be seen. And there are a few new corporations that are using them. I think one was JetBlue, actually. I don't know where they are now, but in the past, and values was one of their things. I recently did a 7-state consultation teaching difficult conversations in healthcare around palliative care and advanced directives across the Midwest for a large healthcare system. They have their values everywhere. Everybody knows their values. So when you're hired, there's their values. There are videos on their values on their website. They have to be able to articulate their values. I have to say, I had not seen that before in the system I'm in and many other systems. They're not articulated. It's assumed you just have them. But we can't assume that. As a pediatrician, can we assume that our 4-year-old knows how to cross the street? No. We have to teach him that. This is how you do it. So that's what's important. So now I'm going to ask you, let's see, we've got 17 minutes. Okay, so I'm going to ask you a question. Now, if I was doing a day-long workshop, I would have you all in small groups, or actually in 2s or 3, turn to the person next to you, tell stories about values, think about them, and then answer this question. But what I want you to do to give you a taste of this and something you can take home is drawing on your professional experiences and your experience as a patient. I think you all said you were patients. What are the core human values that should be present in every human interaction? So I'll let you think about that, reflect on that. From yourself, from your experiences, what are the core human values that should be present in every healthcare interaction? And I'll ask you those. Okay, so raise your hand and say what? Respect, yes. Empathy. Honesty. Curiosity. Non-judgment. Compassion. I'm sorry, say it again. Inclusivity. Other ideas, other values that should be in every healthcare interaction. Accountability. One more. Trust. Okay, you all came up pretty fast with a wonderful group of values. All of those values. Now, what I want you to think about now is, we'll answer this question, where did you learn these values? I didn't teach them to you yet. Where did you learn them? Family. Learned them in family. Other ideas? Where else did you learn them? I'm sorry. Role models and heroes. Learning values from our role models and heroes. School. Often have a lot of people say, well, we learned those in kindergarten. Yeah. The Bible. Okay. Practicing. And people often say we learned it on the swim team, learned it from my aunt and uncle, learned it from our parents. So the point of this is to empower you. You have these values in you. You just told them to me out of the blue. You have these values in you. You can draw upon them. So I encourage you to think about them, to draw upon them, to teach them, to expect them from the people you work with. So you have them in you. Don't forget that. It's within you. So values are extremely important. They affect the way we see the world. They affect how we relate. They affect how we communicate with others. They're sort of the foundation of all of our care. So I want to ask you, how many of you are aware of or have heard of the International Charter for Human Values in Healthcare? Okay, not too many, and this is a fairly new thing. Our charter, this is something that we created. We started in 2011, and in your handouts there are 2 single-page handouts that will tell you more about it for those who are interested. The charter came about in early 2011. We started our work actually in 2010. And it started as an international collaborative effort to identify core values that should be present in every healthcare interaction, just like you thought about for a minute there. The aim is to restore the primacy of core values with skilled communication. That's essential, and I'll get back to that in a minute, for practicing compassionate, ethical, and safe healthcare around the world. This is actually an international movement. The thing that's unique about it is that we had patients, caregivers, clinicians, families, but also many clinicians, educators, researchers, health policy people, healthcare leaders in all different areas. And then we've been working with linguists and communication specialists. So that's brought a whole level. I've done communication, healthcare, and research and teaching for probably 25 years, and now we're bringing in linguists. It's fascinating what we can learn from that. And so what the charter does is it provides a framework for core values essential for every healthcare interaction. And skilled communication, this is key, is how we demonstrate those values. Just briefly, the Charter's initiative of IRCH, we call it IRCH, International Research Center for Communication in Healthcare, 95 members, 17 countries. The co-sponsors, we're in our 3rd year, and our co-sponsors will support us for these 3 years, Hong Kong Polytechnic University, University of Technology Sydney, and Curtin University in Australia. So how did we develop the charter? I'm not going to go into the details because you can find that in the article and you have a handout about that. But it was a 3-year rigorous process. We did the initial very beginning in 2011 early, and to identify and develop a framework of values that should be present in every healthcare interaction. So we used combined qualitative research methods, which you can read there. And we came up with 5 categories. These are categories of values. The interesting thing is that through many iterations, these are 5 categories of values. The fascinating thing to me is that this is universal around the world. Maybe universal is not the right word, but we did it in Asia, we did it in Australia, the Netherlands, the US, all over, everywhere. And people had the same values. Now, they might prioritize them differently. They might say, well, maybe excellence is more important than this, or justice is more important than that, but they had basically the same human values, which I found quite fascinating. We're all human beings, actually. And so this is just one example. This has our most. We just couldn't let go of the sub-values of compassion. And this was also determined by qualitative research. So you can see some of the elements that go into compassion. The idea here is if we can say, well, what are these things? What is this way of being? Curiosity, kindness, motivation to help and heal, all those things, empathy. If we can bring those out, how can we train people to have these? I believe you can learn. There's probably 2% of the population that are probably severe psychopaths, and we can't really train them, but I think all the rest we can, and we can expect them to follow those. And there's similar sub-values and all. This is all the values in the charter. That's a word cloud. So translating values into action, how do we do that? Well, what we have done is that we started, we developed the charter. That's the first thing we did. Then we're trying to operationalize the values. I'm doing a lot of work in this now, ongoing. What does compassion look like? How do we know if we see it? Like you can say, okay, yes, that person was compassionate. What did that person do or act or ask or whatever that made them compassionate? I do some workshops on where they have to think up, okay, it's compassion, but what is it? What does it look like? And they'll say, well, listening. Well, what does that look like? How is that different than hearing? So really deconstructing these values so we can recreate them, we can teach them, maybe eventually have a competency. This would include all healthcare stakeholders, including insurance companies and everyone else, too. That's one of my long-range dreams. So the International Charter, it identifies values, provides a framework. Relationships and skilled communication allow us to demonstrate these values. This is really key. If you're feeling empathic about or compassionate towards a patient, but you're very, maybe you're very quiet, maybe the way you're just who you are, just how you are, they may not know that. They may think, oh, wow, that person's not listening, or they're cold, or whatever, which isn't the case at all. So how do we demonstrate our values? In many different ways. Each of you would demonstrate them in a different way, because we're all different, but it's the same bottom line. So how do we just demonstrate it? How do we show that we're compassionate? How do we be aware of that so that the patient and other caregivers get that information? We have to make our values visible. This is not just touchy-feely, oh, we have a nice charter, you can sign the charter and you're done. No, no, no. How are you going to make the values visible? I've been doing a lot of workshops with Suzanne Kurtz of the Calgary-Cambridge model. We're helping people take communication skills and make them visible. And it's been actually a lot of fun. So just briefly, International Charter for Human Values in Healthcare actually is an initiative of IRCH, our big research center. What we're doing is working, okay, so how many of you are aware of the Charter for Compassion? No? Okay, that's a big worldwide movement. The exciting thing is a month ago, on June 29th in Hong Kong, the International Research Center for Communication in Healthcare, IRCH, became the Asia-Pacific Healthcare Hub of Charter for Compassion International. Charter for Compassion International is an amazing worldwide movement and organization. I would really encourage you to look up their website. I think it's charterforcompassion.org. It's working to bring principles of compassion to life through a variety of practical action in a variety of sectors. They have like 250 or more cities. They have about 1,200 partners around the world. Their sectors include healthcare, which is the part that we're involved with, science, spirituality, peace, nonviolence, business, art, environment, education, and others. And it's an incredible, incredible thing. They have compassionate countries. The Australian Parliament just passed becoming a compassionate, eventually to meet all the criteria to be a compassionate country. Botswana is a compassionate country. Sweden is working on a compassionate country. I spoke at Compassion Week at Stanford in November, and San Francisco is becoming a compassionate city. We had a whole panel of mayors of California cities that are compassionate cities. So they're building compassionate communities. There's a community toolbox to do that. Very exciting work. So the Charter for Compassion, charterforcompassion.org, worldwide movement, worldwide alliance. I'd encourage you to go to that website as well and take a look. So what are we doing? We held our third international symposium on healthcare communication in Hong Kong literally a month ago. We brought together leading leaders to talk about innovative practice to share these educational strategies, practices, cutting-edge research that promote compassionate care, attention to core values, and skilled communication in different healthcare settings around the world. And if you're interested, for all you who do Twitter, it's hashtag IRCCH15, and you could sort of see a little bit about the conference, which is truly fascinating. It was launched with like the Secretary of Healthcare in Hong Kong. I can't remember, Sophie Chan and sort of the dignitaries over there. So they're very committed to bringing compassion to healthcare. More there. And so we have our global initiatives working together. And the collaboration with IRCH, the Charter for Compassion, our International Charter for Human Values in Healthcare, which is a part of IRCH. It brings together Charter for Compassion's Worldwide Alliance of Healthcare Partners. It brings together IRCH's ability to translate communication research into active training and practice to really make it, we call it translational research, a little different than what the scientists may say. And we do that to create compassionate healthcare. So we're really working about how can we do that. And it comes down to relationships. We cannot lose that. And we have to think about the time we have for patients and how we're going to train this and how we can, in a sense, we may have to change the system a little bit. So our hub, we're going to work together. We have developing online courses, consultations, compassion interventions, and values-laden interventions to teach this. And we're pursuing funding opportunities as well so we can continue our work. So I will leave you with, what if compassion was the motivating force behind every decision? Compassion for self, for other people, for creatures in the earth. Imagine how different our world would be. And think about our upcoming healthcare professionals. Who do we want taking care of us as we get older? Of our kids, of our grandchildren. How do we want that to be? Do we want that to be technicians on the factory line with no time for relationships? Or do we want it to be related and caring? And one of the cures for burnout, actually, is having good relationships and not being afraid of them with your patients. They're not your friends, but there is a wonderful sort of refueling that happens with that. So you must be the change you want to see in the world. So think about, what will you do to turn your values into action in your healthcare work and to enhance communication skills to demonstrate that? So we invite you to join us. Those are the two, there's your Twitter hashtag and charterforhealthcarevalues.org and charterforcompassion.org. You can sign them. Signing them is a good start because it's making some commitment to these values. The second thing is we have partners around the world. We welcome everybody as a partner. Doesn't cost a cent. We want to bring people together to work together and figure out how to change healthcare and make it more compassionate and to focus on relationships. So I encourage you to go to the websites. Feel free to ask me. You all are invited, your institutions, organizations, to be partners. Nothing to lose. Oops. Well, there you go.
Thank you very much, Dr.